www.crohnsandcolitis.ca/COVID-19 webinars. And it is my pleasure to introduce Crohn's and Colitis Canada's President and CEO, Meena Mawani.
Thank you, Sarah. Welcome, everyone, and thank you for joining us again at our webinar as we bring IBD experts here to answer COVID-19 questions that are on your mind. Today's discussion takes a look at the IBD medications and COVID-19 risk. Before we get started, I want to mention 2 awards with deadlines that are fast approaching. Last week, I highlighted that our grant review selection process began, which initiated a rigorous process to select our upcoming investments in promising research. I'm really excited about the potential of these initiatives. The Crohn's and Colitis community is doing amazing things to move our mission forward, and we also have a number of awards to recognize, celebrate, and support excellence, like the Physician and IBD Nurse of the Year Awards. Nominate a physician and/or a nurse, IBD nurse, who has made exceptional contributions to the clinical care of Crohn's and Colitis patients by June 30th. These awards celebrate those physicians and nurses who have displayed a steadfast commitment to their patients, serving as both a healthcare provider and patient advocate, often beyond normal office hours. I can certainly think of a few, hint, hint. As you can see, despite the current challenges, we remain committed to supporting and advancing critical research and delivering programs that help people living with Crohn's or colitis today. And to all our dads, wishing you a very happy Father's Day this weekend. This Father's Day is unlike one we've ever experienced, so it's more important than ever for families to stay connected. As such, we've created a special e-card to honor our dads by sending a virtual hug. To send a hug, scan the QR code on the slide. We also heard that many of you loved our gutsy masks. So we now have more on hand if you would like to order one for yourself or a family member or a friend. And with that, who can believe it's been 14 webinars now? Every week since March 19th, we've brought forward topical webinars based on the issues top of mind. The response from our community has been tremendous. We hope that the content, speakers, and resources have helped you through these tough times. All of this information is still available and can be accessed through our website at crohnsandcolitis.ca. Next week, we'll host our last webinar for the summer, unless a need pops up, of course. We'll be watching closely to see how things unfold and if further webinars are needed as we continue to be here right by your side. As always, watch for our emails and at Get Gutsy Canada social media for updates. With that, we are so grateful to our task force who meet every week to discuss policies and recommendations necessary for our community. Thank you to today's panelists, Dr. Jennifer Jones and Dr. Remo Panaccioni. And of course, much appreciation to our fantastic moderators, Dr. Gil Kaplan. He's a professor of medicine at the University of Calgary. He's an adult gastroenterologist and epidemiologist. He's the chair of our Scientific Medical Advisory Council, as well as he's a Crohn's and Colitis Canada board director. And Dr. Eric Benchimol, who is an associate professor and gastroenterologist at the Department of Pediatrics and School of Epidemiology and Public Health at the University of Ottawa, Division of Gastroenterology at Children's Hospital of Eastern Ontario, and he is also the chair-elect of our Scientific Medical Advisory Council. Thank you.
Hi, Meena. Thank you so much.
Thanks, Meena.
Yeah, so like Meena said, this is, I believe, our 15th consecutive webinar since we started on March 19th.
Totally lost.
Yeah, I know. And we also held similarly, I think our 15th COVID and IBD task force meeting last Tuesday. And again, as Meena mentioned, next week is going to be our last webinar until we break for the summer. And similarly, the task force, we're going to stop meeting on a weekly basis. But it was a huge honor and privilege to be able to thank each one of the individuals who are on the task force for the amazing work they've done over the past 4 months. This has been a monumental effort from so many different people, from gastroenterologists, both adult and pediatric, as well as nurses, infectious disease specialists that we have on the committee, plus all the staff at CCC that have come together to help us kind of synthesize all this information and be able to bring this to you on these webinars every week.
Yeah, and I think you said it best last week, is I think when we first formed the task force, we were very worried. You know, I wouldn't say we were scared, we were concerned that we would get a huge number of IBD patients who were very, very ill with COVID-19 considering their immunosuppressed status. And thankfully, that hasn't happened because of a combination of reasons, really a combination of Canada has really fairly well controlled COVID-19 outbreak compared to other countries. And that has resulted in a lower prevalence of disease in the population, which means fewer people are getting sick. We're kind of at that simmering, slow number of cases over time rather than a boiling point, which is great. And so social distancing has worked, and all the measures that you've all taken have worked, but also because it seems like COVID-19 is not as severe as we expected because of the medications that we're using to treat IBD. And so we're going to get into that today as far as which medications you're concerned about, if you're on a medicine, what precautions should you be taking, and what are the risks of developing complications from COVID-19 if you're on certain medicines. So that'll be the focus of today's webinar.
And then that actually kind of brings us to our first poll question that we have for the audience. In the past, we've talked about medications as classes, and we've grouped them up together. And many people have come back and said, well, what about my medication? And even though we often have talked about your medication, we've never actually sat down and went, drug by drug by drug that treats IBD, or class of drugs, and asked the question, what are the safety issues or concerns related to COVID with those drugs? So that's what we're going to do tonight. And we just thought we would start off with a poll question, just asking you, the audience, what are your current medications that you're currently using for IBD? And you can choose more than one, just so we get a sense of the types of drugs that people are taking right now.
We should have some Jeopardy music in the background. But I think, are we about ready to show the results? Excellent. So about 69% are on an anti-TNF or Entyvio, and another 8% on Ustekinumab. So that's well over 3/4 are on a biologic of some sort. And then you've got a quarter who are on immunomodulators, and a quarter who are on Mesalamine, and a small number who are on prednisone. That's good to know right off the bat. And so with that, I guess we will introduce the panelists tonight. So yeah, go ahead.
Do our update first.
Right. So yes, Dr. Pan, we forgot about the update. Dr. Panaccione, you can hide for a second, and let's do the update.
But if Sarah, if I can take over the. Everyone should be able to see my screen here, and as everyone is have seen this update, they're bored with the update and wanted to skip it, but I just wanted to give you a sense of where things are today on June 18th. And if you remember back on March 19th, when we did our very first webinar, there was 230,000 individuals across the world who had tested positive for COVID, jumping to 500,000 a week later. And if you look at the last 3 weeks, on June 4th, when we had a whole session around bathroom access and safety in bathrooms, there were 6.5 million people. Last week, when we talked about the IBD Clinic of the Future, it was 7.4 million people with COVID. And today, over 8 million people have tested positive for COVID, and over 450,000 have passed away. I just want to show you this graph here. I haven't actually shown this in some time. It reflects countries that have had at least 10,000 cases, with green countries having about 1 to 50 cases per 100,000 people, yellow being 50 to 200, red being 200 to 600, and I've added this purple of greater than 600 cases. And one of the reasons I wanted to show this data is just to highlight the fact that there's been a shift in the early days. Asia was the predominant country, and then we had a flip between Europe and US, followed by Canada. And now what we're seeing is a lot of outcomes happening in Latin America and the Middle East. And so we really are seeing these countries now, and also including cases now in Africa as well, really just showing the global nature of this disease. When we turn our attention to Canada, if you remember, 780 cases back on March 19th, 3,400 on March 26th. And if we look at the last 3 weeks. If you remember, on June 4th, there were 93,000 Canadians who have tested positive for COVID. On June 11th, that number was at 97,000, and as of this week, we're approximating nearly 100,000 Canadians who have tested positive for COVID and over 8,000 who have passed away. These are the number of cases per province, and again, we can always see that the highest number of cases are highest in Quebec and in Ontario, which are the most populous regions. And then when we look at the incidence of COVID per province, we see that Quebec remains to be amongst one of the hardest hit provinces. And if you remember that map I showed you of the world, Quebec's incidence is on par with some of the hardest hit countries in the world. You can see here where Ontario is at 226 cases per 100,000 people living in the province. Alberta here at 169,000, and Manitoba continues to do very well, and similarly with BC and Saskatchewan. These are active cases, and we see active cases kind of falling week by week in all provinces, but still recognizing that Quebec and less so now Ontario are having the most active cases. And this is important data. These are new cases in the past week, and we can see that actually in the Maritimes there's very few new cases. We can really, even these numbers have fallen off for Quebec and Ontario as well. Just to kind of show you outcomes, this is data from Statistics Canada, and we can see that the majority of Canadians who've been infected by COVID have had mild disease where they've been able to manage their COVID at home, 8% in hospital, 2% in the ICU, and the case fatality rate is 8%. Again, this is stratified by age, and we can see that if you're young, under the age of 20, the vast majority of children have, recovered from COVID at home. Additionally, the group from 20 to 59 have actually done very well as well. And this is in contrast to countries like the United States, where they've seen a lot more morbidity in this age group. But of course, as I've shown every week, our elderly population is the one who's been hit the hardest. And it's not just the elderly population in general, but when we look at the Secure IBD registry, again, it's our elderly population who have had ulcerative colitis and Crohn's disease, who have come with COVID, who have also had high rates of bad outcomes such as death or needing to be in the ICU. And I just, before we kind of slip away from my presentation, I just wanted to show you this interactive secure registry database. And the reason why I just wanted to highlight this again is just because we're going to be talking about data from this database. And I just want to give you a bit of context of what it is. So this is a global international initiative. This was something that we talked about in detail on March 23rd in our webinar. But just to let you know that this is a self-report database. So if a physician has a patient who has COVID, they can actually report information directly into this database. As of June 15th, there's been over 1,500 cases of patients with IBD who have been reported. This kind of shows you how many cases have accumulated since the very first case was reported back on March 13th. I showed you earlier about the age stratified outcomes, where we can see that the risk of death, which are these red bars, are highest as you get older. And again, anyone under the age of 30, there's never been a case report of death in the world in somebody under the age of 30 with IBD. We're going to talk a lot about treatment, so I won't go into the details now, but if you want to explore this website and look at some of the data, this is all the drugs that we're going to be talking about today in the panel, and we'll go into it in a lot more detail, but just to let you know, but this is where some of this data resides. So with that, and the other thing I just wanted to show is you can click on these countries and it actually tells you how many cases are in Canada versus how many cases are in the US. And so with that, we'll kind of bring Eric back and we'll introduce the panelists and we'll start talking about drugs.
Sorry about that, Gil. I think I jumped ahead a little bit, but thank you for the update very much. Now we will introduce tonight's panelists. So firstly is Dr. Jennifer Jones, who's an associate professor of medicine at Dalhousie University and team lead of the Nova Scotia Collaborative IBD program at QE2 Health Sciences Centre in Halifax, Nova Scotia. Dr. Jones spent some time in Saskatchewan, and then in 2014, she returned to Halifax to take on her role as medical team lead for the Nova Scotia Center for Nova Scotia Collaborative IBD Program, and chair of clinical research in the Division of Digestive Care and Endoscopy in the Department of Medicine. Her clinical and research passions relate to care care and quality improvement through health system integration and collaborative care initiatives, and as well as implementation of best practice at the patient level and patient-centered program development, access to care, and IBD epidemiology. So Dr. Jones really is involved in a lot of clinical epidemiology and health services research. And also joining us tonight, Dr. Panaccione, who has joined us at least once before, I think a couple of times. Dr. Panaccione is Director of the Inflammatory Bowel Disease Clinic and Director of Gastrointestinal Research, as well as Professor of Medicine at the Cummings School of Medicine at the University of Calgary. He's an internationally renowned expert in IBD research, but especially in clinical trials and drug development of new drugs for the treatment of IBD, and certainly was heavily involved in the trials to assess whether the drugs that we're going to talk about tonight work, particularly the anti-TNF biologics, the Ustekinumab and Vedolizumab. So we have really an expert in drug development here who will be talking about drugs tonight. So that's great news. So thank you both for joining us, but we're actually, Gil and I are actually going to participate as panelists as well tonight. And so I believe the first question will be for Gil, but let's ask this question to the audience first. So the first question is actually to the audience. So what we want to know starting off, and we're going to ask you the same questions at the end of the webinar to assess whether you found this useful, whether you learned something. So how well do you know your medications and how your medications affect your risk of COVID-19? And that could be development of COVID-19 or outcomes of COVID-19 if you already get it. Do you have no knowledge, poor knowledge, average knowledge, good knowledge, or very good knowledge? So hopefully everybody has had a chance to answer. And shall we show the results? So most people are average, which works well, right? If you're average, you're average. So I'm hoping that at the end of tonight, we'll be able to up that a little bit and make it a little bit more towards good or very good. I hope that you feel comfortable in learning about this tonight, as well as asking questions. We're hoping that we'll have some time for you to ask questions. Just a reminder that if you put in your questions in the chat box, Sarah and the team at Crohn's and Colitis Canada will try to grab the common themes first, but then also try to answer your personal questions. Please don't try not to ask a question specifically about your personal health. We can't answer questions about you specifically, but if you phrase it in a way that's general knowledge and you're trying to understand the risk of medications or the risk of other treatments, that we should be able to answer. So with that, we'll go to the first question. And the first question for Gil is really to start to review a very, very common medicine type that people use for IBD, particularly ulcerative colitis, and that's mesalamine, sulfasalazine, and the 5 aminosalicylate medications. So medications like Asacol, Mesavant, Salifalk, Pentasa, and so on. So Gil, can you tell us a little bit about these medicines and then move on to how they affect the risk of getting COVID-19 or of having a bad outcome from COVID-19?
Yeah, absolutely. And from our poll, I think it was roughly a quarter of our audience has actually been on one of these medications. And I suspect many more have probably been on it at some point in their IBD history, because these are very commonly prescribed medications. And something that we found a little bit of surprising information from the COVID world. And so what I wanted to do is just give you a little bit of history of these medications and then talk a bit about their impact in COVID. And so sulfasalazine was one of the original drugs that we have for the treatment of inflammatory bowel disease. It was actually created in the 1950s to treat rheumatoid arthritis. And we know with a lot of patients with arthritis that some of them actually will have colitis as well, including some ulcerative colitis patients will have arthritis as well. And so those patients with arthritis who were given sulfasalazine and also had colitis, they found that their colitis got better. And that led to some studies looking at it as a treatment for ulcerative colitis, and it became one of the earliest treatments. And really, sulfasalazine and prednisone, which was also discovered in the 1950s, were the predominant medical treatments for ulcerative colitis and Crohn's disease, heading all the way up into the 1980s. The problem with sulfasalazine is that there's a sulfa component on the molecule, on the drug, and there are some people who have allergies to sulfa, and if you take really high doses of sulfa, people were also experiencing some dose-related side effects. And so in the 1980s, scientists had discovered that the medicinal component of sulfasalazine, the part that actually had that anti-inflammatory effect for ulcerative colitis, was a molecule called 5-aminosalicic acid, or we often call it 5-ASA, which is a little bit easier to pronounce. And by isolating 5-ASA, they created a new class of drugs called mesalamine. Now in Canada, the most common brands of mesalamine are Asacol, Pentasa, Mesalamine, and Salifalk. And depending on which one of these brands, you'll find them as oral medications, as rectal medications, either enemas or suppositories. And essentially, all of these mesalamine drugs have the exact same medicinal component, this 5-ASA molecule. The difference between them is how they're delivered into the intestines. And that's why there's different parts, but essentially they have the same drug and the same potential side effects. Now, mesalamine is most commonly used to treat mild ulcerative colitis, but they've also been commonly used, particularly historically, for Crohn's disease. But in more recent years, gastroenterologists have realized that mesalamine has been less effective for Crohn's disease, and we're seeing that we're doing less and less prescriptions of mesalamine for Crohn's disease as a result of that. Now, the way that they work is they're essentially mild anti-inflammatory drugs that work at the level of the intestine with relatively minimal absorption. And that means there isn't a lot of the drug that gets into your blood and into your other organs. And this means that it has very mild immunosuppressive effect. In fact, we really don't think that systemically outside the bowel that mesalamine or sulfasalazine suppresses your immune system to significant effect. And that's the reason why many of us will quote that we don't believe these drugs increase your risk in developing an infection. And so now we're kind of turning to the COVID era when we were first starting to think about, what are drugs that are safe to use from a COVID perspective. Virtually all gastroenterologists would widely believe that mesalamine should really not have any major impact of a risk of developing a complication related to COVID or increasing your risk of infection, because it really don't suppress your immune system systemically. Now, we have seen some surprising data, and this is more recent data that's coming out of the Secure IBD registry, showing that people who were taking mesalamine compared to those who were not taking mesalamine had a higher propensity for more severe complications from COVID. And this was actually quite baffling or puzzling because, as I was saying, these are drugs that don't suppress your immune system. So how potentially could these cause these types of more severe complications? Well, one of the reasons why this is an important finding is just to recognize that the Secure IBD Registry database has some limitations to it. And this is important not just for mesalamine, but for all the drugs that we're going to be talking about later in the program. And so one of the things is that it's patient self-reported, so we're more likely to report people who are sicker as compared to those who are less sick. Additionally, we know that mesalamine is used quite commonly in countries where they're poorer countries that don't have as much access to biologics. And it may be that in those countries, their healthcare systems don't have as adequate response to COVID, and again, may be related to more severe complications. Additionally, we're using mesalamine more commonly in older patients than there are in younger patients, partly because we worry a little bit about immune suppressive risks in older patients. And we know that older patients are more likely to have bad outcomes for COVID. And additionally, as I was telling you before, we're using mesalamine less and less for Crohn's disease, but we discovered in the Secure Registry there was a lot of Crohn's disease patients who were getting mesalamine, and maybe this is an indicator of poor quality of care of their IBD. All of these factors we call are what we call confounders, or other potential explanations for a relationship that we see in a study like the Secure IBD Registry. But having said all of that, we do want to be prepared that there could be the potential that there might be some direct effects. And one potential explanation for this is that we know one of the most common causes of a severe complication of COVID, causing you to go into the intensive care unit, is if you develop what's called a cytokine storm, with your body's immune system is attacking your lungs very aggressively. And we know that a drug like mesalamine would not have any impact on treating the cytokine storm. And what you're going to learn a little bit more from my colleagues who talk about some of the other drugs is some of the other drugs that we use are actually being used to treat this cytokine storm. And so we may be indirectly seeing that effect as well from these results. Again, there's a lot of people right now, basic scientists, who are taking this data and actually starting to explore animal model research to try to understand if there's a potential mechanism between mesalamine and COVID. And I think right now, if we think about how gastroenterologists are viewing this data, for the most part, we're still guarded by this information. Right now, if you're currently well and you're on mesalamine and you're not having any issues, we still recommend you to maintain that therapy, because we think if you stop the medication and flared, you'd be in a worse scenario. But what you might find that's a little bit different from a clinical practice perspective is that if you become sick on mesalamine, we might be a little bit more aggressive in getting you on one of the biologics or some of the other drugs that we're about to talk to if mesalamine's not working for you. So with that, I'll pause, and I'm keen to get if there's any other input from my colleagues.
Yeah, so Remo, Jennifer, do you have any concerns about using 5-ASA medications right now with COVID? Would you stop them if somebody gets COVID?
Yeah, I mean, I'm not concerned. I think that, again, there seems to be an association towards worse outcomes in the secure IBD registry. But I think that there's a lot of confounders or other things that Gil has already pointed out that may be responsible for that have nothing to do specifically with the medication itself. So I think, you know, the way I think about all of these drugs is, do I think it increases your risk of getting the virus itself? And the answer is no. So you should continue it. Do I think if you were to contract the virus, do I think it increases your risk of developing the disease? Probably not. And does it increase the risk of developing complications of the disease? I think we need to sort of keep our eye on it, but right now I wouldn't recommend either stopping or a dose decrease. I think Gil's comment on making sure that if you are on this drug and for whatever reasons you're starting to have symptoms, that we should transition you probably to a therapy that may get your disease under control a little bit more quickly.
Yes, I would completely agree with that. And mechanistically, if you just think about the biologic plausibility as to why someone on this type of medication would have worse COVID-related outcomes, it doesn't really have a lot of plausibility. And so for all of those reasons that have just been stated, in addition to that, I would have no issues with treating patients with this class of medication.
That's great. So I think we can probably move on from the 5-ASA medications unless you have anything else to add, Gil.
No, I think that was covered well. And I think what would be interesting is we talk a little bit later on about some of the other drugs that have the potential to address that cytokine storm that I mentioned. And that's another potential way that we might be seeing kind of the opposite effects. Now, having said that, the other drugs that we want to kind of review are the corticosteroids. And Eric, I would be keen for you to be able to answer this question and help us differentiate different types of steroids. What's the difference between prednisone and budesonide, and how do you feel their risks related to COVID impact IBD patients?
Yeah, absolutely. So this is a big topic, Gil, so give me a few minutes to go through everything. But essentially, prednisone and the relatives of prednisone, so all the systemic corticosteroids, have been used for many, many decades to treat inflammatory diseases and infectious diseases. Prednisone is the most common one that we use for outpatient oral treatment, so treatment by mouth, but some patients may have been on hydrocortisone or methylprednisolone by IV when they're very sick, all types of steroids. The doses aren't exactly equivalent, which we'll talk a little bit about later, but in general, we consider high dose of those medications to be the equivalent of 20 milligrams or more of prednisone, because very old studies have shown that that's the dose where you're most at risk for your adrenal gland being suppressed. And your adrenal gland is necessary to produce stress hormones and also necessary to prevent shock as you're fighting infection. So 20 milligrams is a bit of a magic number that we've used for many years, and we'll get back to that when it comes to COVID, but there's nothing really magical about that number. It's fairly arbitrary. Whether you're on 15, 17, or 22, it's probably all around the same. But just remember that 20 milligrams or more in general. Prednisone, we know, downregulates or suppresses some of those inflammatory cytokines, those chemicals that drive inflammation in the body, and really does a number of different chemicals, cytokines in the body, including IL-1, which we'll set aside, NF-kappa beta, but then what's important here is TNF-alpha is also suppressed by prednisone. And obviously we know that anti-TNF therapies target TNF alpha as well. Also IL-6 is suppressed by prednisone. And actually IL-6 is one of those cytokines that seems to be way up and causing that part of that involvement of that cytokine storm that we see in COVID-19. So that may be important when we talk about some of the newer data that has looked at prednisone for treatment of COVID-19. Prednisone does all sorts of other things to suppress the immune system and reduce inflammation, but because it's really a systemic medicine, it affects the entire body and multiple cytokines, it has side effects, obviously, and many of you know the side effects of prednisone, including moon phases, acne, increased risk for infections we've known from the past, bruising, stretch marks, high blood pressure, diabetes, and long-term it can cause osteoporosis, cataracts, glaucoma, and growth failure in children, which is important in our practice. So certainly in children, we don't want to use prednisone for long periods of time, and we don't want to use high doses for too long or too often. And the same goes for adults. The side effects are big. And I think we kind of at the beginning, prednisone's been used for Crohn's, probably since Dr. Crohn discovered Crohn's disease. I think it was pretty much tried around very, very early. And the first clinical trials were actually involving prednisone against placebo and also sulfasalazine, like Gil mentioned, against placebo. That was the first clinical trials in North America and Europe in the late 70s, early 80s. Now, a newer type of steroid has come out more recently, kind of in the 90s, called budesonide, and we've known that for asthma for a while. It's called Pulmicort when you inhale it, but in Crohn's disease, it can be called something called Entocort or Cortiment, are the common brand names in Canada. Entocort, that form of budesonide, is designed to be released in the last part of the small bowel and first part of the large bowel. So it's most effective for Crohn's in that area, whereas Cortiment is designed to be released in the colon. So it's actually most effective for colitis, typically ulcerative colitis. Those steroids are actually they're absorbed by the body, but they're rapidly broken down by the liver. So they don't have the side effects. They don't stick around long enough to have the adrenal suppression side effects that prednisone does when they're used in the short term. So they've been shown to be very effective to induce remission, both prednisone and budesonide, but they're not effective to maintain remission. So you shouldn't be on it on the long term. And even budesonide has been shown to suppress your adrenal gland when you're on it for a year or longer. So we don't use these medicines long term. And so what we think is that budesonide probably doesn't alter your body's ability to fight off infections to any great extent, as long as you're on it in the short term and not the long term, okay? So now steroids, let's talk a little bit about steroids, okay? So talking about steroids in COVID-19 in patients with IBD, really in March or April, there were really some mixed studies out of China. Some studies indicated that steroids helped with mortality from COVID-19, and others showed that there was an increased mortality rate with an increased dose of steroids. So in one study, it was for every 10 milligrams more you got of hydrocortisone. 10 milligrams of hydrocortisone is about the equivalent of 2.5 milligrams of prednisone. Every, let's say, 2.5 milligrams of prednisone increase resulted in a 4% increased mortality from COVID-19, okay? And there were patients who got high dose steroids when they were really sick to treat the lung inflammation that was going on, called ARDS, that lung inflammation that we see that kills people with COVID-19. So these patients were sick when they got steroids. They weren't the typical IBD patient where their lungs were, they get mild COVID-19 and their lungs are not affected. But at the time, the WHO recommended against giving steroids for sick COVID-19 patients, unless there was another reason to do so, like that they had asthma on top of it, and we know steroids work with asthma. From that, multiple societies like the British Society of Gastroenterology, as well as the British Society of Rheumatology, the International Uveitis Study Group, and other chronic diseases that commonly use prednisone, said that for patients who are on 20 milligrams or more of prednisone, they might be considered to have risk of bad outcomes from COVID-19. And so they recommended against using a high dose steroid or trying to reduce it if at all possible. Then we get to the Secure IBD registry, and the publication probably 4 weeks ago now that was presented at one of these webinars that Secure IBD published. The first 525 patients confirmed to have COVID-19 who had IBD. And they found that when you adjusted for other confounders, other variables, including how severe your IBD was and where you lived in the world. Systemic steroids, if you were on systemic steroids, you were at 6.9 times the risk of having severe COVID-19, even when you controlled for these other factors. And what they defined as severe was ICU admission, ventilator use, and or death. So any one of those three things. Now, it's important to note that we don't have a clear marker of disease activity. So it was really what the doctor said was no disease activity, mild, moderate, or severe. So very kind of crude markers. And like Gil mentioned earlier, there's probably a reporting bias here where that the more severe cases of either IBD or the more severe cases of COVID-19 were more likely to be reported to the secure IBD registry. And so this finding may not apply to everyone. But I think it's worth noting that in the newer data, so 1,500 patients now on the Secure IBD website, covidibd.org, the people on steroids had a 19% chance of that severe outcome of ICU admission, ventilator use, and or death. And that's unadjusted for any of, we can't adjust for the confounders at this point. This is just our reading of the website. And that 19% compares to 2% who had the severe outcome if they were on an anti-TNF therapy alone, and 9% if they were on an anti-TNF therapy and an immunomodulator like azathioprine, Imuran, or methotrexate. So quite a bit higher than those two other groups. So there still seems to be a signal in the 1,500 people, and that severe outcome doesn't seem to hold with budesonide or steroid enema medicines. Those don't seem to cause the same type of bad outcomes. But there was only a small number of patients who were on budesonide, and only about 10% of these had severe outcomes. So it's important to remember that steroids may be a marker of severe active inflammation, and maybe that's the problem, with the patients who get COVID-19. If you have severe active inflammation, maybe you're more at risk for severe outcomes, and it's not necessarily the prednisone. But until we know that for certain, we're cautioning that if you're on prednisone, please try to keep isolated as much as possible, stay home, don't go to work, try to prevent yourself from getting COVID-19 as much as you possibly can, wash your hands, physically distancing, and all of those things, because steroids seem to be the major thing that we're seeing in the Secure IBD registry that might lead to bad outcomes. So that was a lot of information. I'll pause there, Gil. Do you have any questions about that for me? Oh, you're muted, Gil.
Sorry about that. It was a phenomenal overview of steroids, for the history to the current issues and separating between prednisone and budesonide. And maybe I can turn to Remo to get your thoughts on this. This is one of these things where I think one of the things that Eric mentioned was we don't have a really good marker for disease severity, meaning that the sickest patients that we're currently taking for are the ones who are more likely to prescribe prednisone. And just being sick is, being a risk factor for bad things happening to you. We've known that for many things, even outside of that of COVID-19. And so just curious on your thoughts on that. And can we still, as gastroenterologists, prescribe prednisone during a pandemic? And how do you manage it?
Yeah, again, I think that, just to agree with Eric, I think that all of the data across what we call immune-mediated diseases, so these diseases that have an immune basis, sort of suggests that higher dose of steroids may be associated with worse outcomes. I think that we just need, again, to be a little bit careful about this from the perspective of, is it the high dose steroid that the patients were on because of their disease, for example, or is it patients who are on high dose steroids and have been on long-term steroids and may have some what we call adrenal insufficiency, which we don't have that granularity within the Secure IBD registry. So there could be other reasons. And once again, similar to 5-ASA, prednisone is a very, very inexpensive drug and is used in many, many countries that don't have access to these other therapies. And so we may be seeing some degree of a marker of the healthcare system rather than the prednisone itself. That being said, I think that there's enough in the data that if you have other options in patients in certain clinical situations, you may want to go in a different direction. And certainly I can only speak to, for example, our patients who've come in during the pandemic with severe ulcerative colitis, and Gil, you've been on call during the pandemic. It's not like we're not using IV steroids in those patients to try to get them better, right? So it still has a place. I think we just need to be cognizant of where we're using it and what the alternatives are in the clinical situation. And then I guess for Eric, one of the things that we might want to talk about is there's been a more recent study that came out as a press release that sort of may confuse things a little bit. And I don't know if you want to comment on that.
I can. I was giving people a break so they didn't have to hear me for so long. But yes, absolutely. I'm ready to comment on that. So that what Remo is talking about is the recovery trial. So let's go back a little bit and let's look at SARS, obviously in the early 2000s, and MERS, which is the Middle Eastern Respiratory Syndrome. And those are both coronaviruses, both outbreaks / epidemics. They tried steroids for those patients who were very, very sick with ARDS, again, that pneumonia, that lung problem, lung inflammation problem that people often died of when they got SARS or MERS. And what they found was that patients who got steroids actually had relieved symptoms of their lung inflammation. So the lung inflammation got better, but the clearance of the virus from the body actually was delayed. So they had the infection for longer, and overall steroids did not improve mortality rates in SARS and MERS. But nevertheless, because there was a signal there, I think for those coronaviruses, as part of a very large trial in the UK, they wanted to look at whether steroids would help with COVID-19. So this is called the recovery trial. And you may have heard about the recovery trial a few weeks ago, actually probably a week or two ago, feels like forever, but that was the trial that really fairly conclusively said that hydroxychloroquine did not really help very much in COVID-19. So this actually is testing 4 different drugs against placebo, and actually they've just added a 5th drug, which I'll talk about in a second. But the 4 drugs are an antiviral medication, which the results have not come out yet, the hydroxychloroquine, as we mentioned, azithromycin, which is part of that Z-Pack you may have heard about from the US, and then finally low-dose dexamethasone. And they just actually got permission to add in tocilizumab, which is an anti-IL-6 biologic, into the trial. Okay, so remembering that prednisone, IL-6 is very much involved in this severe inflammatory response in COVID-19. They're going to look at actually blocking IL-6 and whether it results in better outcomes for people with COVID-19. So we'll talk about the dexamethasone, the steroid. So the intervention was really a low dose dexamethasone, oral or IV, for 10 days in people who were hospitalized for COVID-19. And the dose was 6 milligrams every day, which is basically, if you convert that to prednisone, it's about 40 milligrams of prednisone every day for about 10 days. Okay, so a similar dose to what we use to induce remission in Crohn's disease. Dexamethasone, it's longer acting than prednisone, and it may act slightly different. It might affect different hormones, slightly different than prednisone, but overall, it does reduce inflammation. We use it frequently in kids who get croup, as well as in meningitis from Haemophilus influenza type B. So that was in the old days when we weren't vaccinated for that. But in this trial, their primary outcome, the main thing they were looking at, was mortality. So all-cause mortality for any reason. And then they also wanted to look at outcomes like duration of hospital stay, how long you needed a ventilation for, did you need a ventilation, and then a composite endpoint of death, ventilation, or something called ECMO, which is like a combination of ventilation and bypass, cardiac bypass. So about 2,100 patients got dexamethasone, and about 4,300 patients got the usual care. So not a treatment, but how we would normally treat COVID-19, which was just supporting people, making sure that they're getting oxygen and ventilating as needed. So the results, I have to caution very strongly that we have only seen a press release, okay? So we've gotten caught before with COVID-19, and I think we're gonna talk about this next week. Just a little teaser for next week, we'll talk about the topic. But we have been caught before with publicizing even scientifically published studies that have turned out to be bunk, okay? And certainly pre-publications before peer review, a lot of them have not borne out the way we had hoped. And this is just a press release, okay? So we haven't even seen the scientific study in writing yet. We're going by the press release from University of Oxford, mind you, and this is a very, very strong and reliable group of a large number of investigators in the UK. And University of Oxford has seen the results, as has the WHO, and they said that these look like reliable results. So we have to trust the people who have seen the data, but we have not personally seen the data yet. Hopefully in the next week or so, we'll see the final result, but it's very, very promising. So the people who got dexamethasone, the risk of death was reduced by about 1/3 in ventilated patients and by about 1/5 or 20% in patients receiving oxygen only. Okay, so in the most severe patients, it actually reduced death, which was and a very strong reduction in death. And we don't usually see 1/3 lower rate of death in any drug trial in patients this sick. So it's really, really promising. Important to note that there was no benefit in patients who did not require respiratory support. So if you didn't need oxygen and you didn't need a ventilator, there was no significant benefit of receiving dexamethasone. So please don't go out and ask your doctor for dexamethasone right now. You will get it if you need it when you're in hospital. You should not be taking it as an outpatient, and you should not be taking it to prevent COVID-19, okay? So really the bottom line is that if you treated 8 ventilated patients with dexamethasone, you'd prevent 1 death, okay? And that's a great outcome. If you treated 25 patients who needed oxygen only for COVID-19, you'd prevent 1 death in those patients. So again, a really nice outcome. And when we start to combine with some of the antivirals that we're looking at and potentially some treatments coming down the road, like the biologics, we're very hopeful that we may be able to reduce the death rate from COVID-19. But at the moment, things are early, and you know, it's not the same thing as being on prednisone for 30 or 40 or 60 days, right? This is a 10-day course only, and then they stop.
Yeah, that's a great overview. And I think, Remo, you had actually described such a key point, which is this virus has different phases of infection and different phases of complications. And in one phase, a drug could serve as a risk, and in another phase, it could potentially serve as a benefit. But more importantly, and I think anyone who has a few hours to kill and want to watch every one of these webinars, 15 in a row, you'll see that this information is evolving dramatically. And that's where we have to be open, that all of these studies, there's potential biases, limitations. We need to be careful in interpretation of everything, and recognizing the comments that we're making today are different from the comments that we made just a few weeks ago or a few months ago. And in a few months from now, we might be looking back at June and saying, you know what, actually, the real things that we're looking at now look like this and that. And that's the one thing we just want you to leave. And that's medicine and that's science. It is an evolving, rapidly changing discipline, particularly in the context of a pandemic like this, where we're dealing with a disease that didn't exist a year ago.
And Gil, I just want to run through a couple of questions in the chat box, because I think we can get through them really quickly. They're all about prednisone, and we can sort of address them and move on from prednisone after this. So does the risk decrease when your prednisone dosage decrease? We think so. Again, the number that we're giving is 20 milligrams and above of prednisone daily is where you're at higher risk. The number is fairly arbitrary. So if you're on 17.5 or 15, you may still be at higher risk, but that's sort of the number we give. And the lower dose you're on, the less risk of complications from COVID-19. We think, we don't know that for sure. The data is not there yet. And then the next question was, does the SPHERE outcome include individuals who were on prednisone in the past and not currently? So no, we think that after a few weeks of being off prednisone, your risk returns to normal and your body returns to normal. That's not always the case. That adrenal suppression can happen, weeks out from being on a long course of prednisone. So you have to speak to your doctor about whether you think that's an issue. But certainly if you were on it 6 months ago and haven't been on it since, that you're probably not at risk for fighting, any problems fighting COVID-19 compared to others. Would a short dose of high dose IV prednisone be more safe than long-term use of prednisone? Maybe Jennifer, I'll get you to answer that question. I'm not sure how to answer that. Oh, you're muted.
I'm muted.
And maybe do you want to repeat the question just for the audience as well?
Sure. If you had a choice, should you use a short high dose IV steroid? So it wouldn't be prednisone, but it would be methylprednisolone or hydrocortisone. Is that more safe than using a long-term prednisone orally?
Yes. Well, I think a lot of the steroid-related side effects come with, cumulative exposure. So I had to pick my poison, I would probably choose the high dose, hit them hard, short-term steroid approach. But obviously, the chronic exposure to steroids is a big concern. And as with any therapy, our goal is to wean patients off steroids as quickly as we can.
And I mean, it's important to note that I mean, high dose 5 days may settle inflammation a little bit, but it has not been shown to induce a real remission for Crohn's disease, right? So it's unusual that we, as gastroenterologists, would use like super high doses for 5 days and then stop. Asthma they do, but not so much in Crohn's disease. And then Remo, how would you define long-term use of prednisone? I said long-term. Is it months? Is it years? Like what's long-term to you?
Yeah, I mean, there's different sort of tapering regimens and everything, but if you're on steroids for more than 3 months in general, that we would consider that long term. So there's, if you're on more than sort of one course in a year, that's considered what we call steroid dependency. So those are both considered long-term. One of the things that I just want, I'm not sure if you said this, Eric, is we don't, even if you're on 20 milligrams or above prednisone and you're listening to this, the one thing you should absolutely not do is stop your prednisone abruptly, right? And I'm not sure if you had mentioned that.
I should have. We've said it multiple times in past webinars, but you're absolutely right to bring that up. Thank you, Remo.
Yeah, so for the same reason or the rationale that Eric had explained, unfortunately, your adrenal glands are very, very lazy and they stop working and they don't wake up very quickly if you stop their prednisone. So if you have what we call exogenous steroids, you're taking steroids, your adrenal glands take a little while to wake up, and that's why we actually taper prednisone. So if you're on a dose of prednisone or you've been on any dose, and you abruptly stop it before 7 days of being on that drug, you're at, or after 7 days, you're at risk. So please don't stop your prednisone. Always taper off of it. And if you've been on it for a very, very long time, you'll even notice small changes. Your body may react to it. So it's a very important thing. If you're on prednisone, you're on for a reason. If you want to get off, always speak to your doctor.
Absolutely.
And Jen, I'm wondering if you could talk a little bit about budesonide. I know Eric covered it earlier, but one of the questions from the audience was, if you've been on budesonide for a very long time, does that impact your risk of steroid side effects? And so just because we've been so focused on corticosteroids, prednisone, just wondering if you could give us a little bit of insight onto budesonide, and that's going to be entocorticordament.
Yeah. I mean, budesonide, as I'm sure many of you know, is a pretty safe steroid option that the liver eliminates or breaks down 90% of it after it's absorbed from the bowel. So it tends to work most effectively in the last portion of the small bowel in the right colon. So for individuals with mild to moderate disease, it's a very attractive option, and it would certainly limit your systemic exposure to the steroid. But it is still a steroid, and although studies have shown that it's significantly safer than a systemic steroid like prednisone, there is, over the long term, of cumulative exposure, even to a medication like budesonide, there's potential for steroid-related side effects, but much less so than with a medication like prednisone. But at the end of the day, if you have severe disease, you really should choose the approach that's going to most effectively and rapidly induce remission to keep you out of hospital, and then discuss longer-term treatment options with your gastroenterologist.
And there's another question about, does prednisone's effect, is it current or even past exposure? Let's say you were on prednisone 6 months ago, could that potentially affect it? And we believe that once you've stopped prednisone and you're weaned off of it, the effects of corticosteroids should come out of your system. Sometimes the side effects and the complications you sometimes get with prednisone can last for a bit or a while, but that immunosuppressive risk is gone. So really, this is your current use as of today. There was also a question about Humira and Entyvio, so I thought maybe this is a good opportunity to pivot into another realm of questions for another class of drugs.
Absolutely. So this one is for Remo. And Remo, let's talk about anti-TNF therapy and how do anti-TNF therapies, and they're listed there, the infliximab types, which are Remicade, Renflexis, Inflectra, as well as the Humira, adalimumab, Simponi, golimumab, and in the US, certolizumab. How do they affect your risk of developing COVID-19 and your risk of bad outcomes from COVID-19?
Sure, thanks, Eric. So if we go back, I mean, it is an interesting story even with anti-TNF therapy. So anti-TNF therapy has really become a cornerstone of treating inflammatory bowel disease, both Crohn's disease and ulcerative colitis. And you could see by the response that you in the audience gave that there's a significant proportion of you that are on these therapies. As mentioned before, they're used in a variety of immune-mediated diseases, including rheumatoid arthritis, ankylosing spondylitis or arthritis of the back, psoriasis, psoriatic arthritis, uveitis. So we have a great experience with this over time. One of the things that is interesting and why we were a bit concerned about anti-TNF therapy at the beginning of the pandemic or uncertain about it is because the very first clinical trial that an anti-TNF was ever used in was actually in the intensive care unit to treat something called SIRS, or systemic inflammatory response syndrome, not dissimilar to what we're talking about during this pandemic and what happens when patients are in the ICU. And in that particular study, which was done over 25 years ago, it was prematurely halted because patients actually did poorly and actually died during that study. Now, anti-TNF in general is a systemic immunosuppressant. It has anti-TNF as a molecule, has a lot of effects on the immune system. It's responsible for controlling and upregulating other what we call pro-inflammatory cytokines. It's responsible for trafficking of inflammatory cells to the gut in some fashion, and it's also important in maintaining its effects on maintaining the barrier function of the gut. That being said, when it started, I'll go through it the same way, is we weren't sure if you were on it. Was it going to increase your risk of because it was a systemic acting medication? Was it going to increase your risk of developing SARS-CoV-2 or the virus? And was it going to increase your risk of developing disease? And is it going to increase the risk of developing some of the complications that we'd all be concerned about? And so as time has evolved on the pandemic, I think we've gotten some of these answers, not only within the secure IBD registry, but in parallel or similar registries done in those other diseases where anti-TNFs have been used. There was enough concern in the beginning that in China, for example, one of the first IBD cohort that came out of China, they essentially stopped all of these medications that were biologics during the early days of the pandemic. As an organization, the International Organization of IBD, and then later this task force, in the early days, we again were uncertain. But I think there's been several data sets, and the secure IBD data set is one of the most important ones that, so as far as developing complications of the disease, it doesn't appear that, at least if you're on anti-TNF monotherapy, which means one of those drugs that we just mentioned that's mentioned on the slide, if you're on this alone, the risk of having that sort of poor outcome, which was either having to be on a ventilator with a tube in your mouth or being in the ICU or death, that the overall risk right now in the 1,511 patients sits at about 2%, which is a quarter of what we're seeing in the overall population. So that was very, very good news. That is very consistent with what we're seeing coming out of other registries in other immune-mediated diseases, to the point where there is actually a trend that it may be protective for the reasons that, because when you block this, you're blocking other cytokines, including IL-6, that if you're in a certain stage of the disease, it may protect you against cytokine storm. So again, that's the hypothesis there. Now, that risk does change if you're on an anti-TNF and you're on an immunosuppressant medication such as azathioprine and or methotrexate. So that 2% absolute risk does increase to 9%. So in that, if you're just comparing numbers without doing what we call logistic regression analysis and looking at other factors, that 9% number is similar to the overall sort of cohort number. So suggesting, again, that there's probably not an increased risk, but there's more risk than being on these drugs alone. So what does that really translate into for you as an individual patient, and how it's potentially changed our practices? So number one, if you're on an anti-TNF therapy, most of us are not recommending that you stop it, so you should continue it. Number two is I'd be comfortable starting an anti-TNF therapy, during the pandemic, if need be, but as opposed to starting it perhaps with an immunosuppressant, which we do after discussion with the patient and the pros and cons of doing that, I probably wouldn't have that discussion, and I would start this as monotherapy. So that's that part of it. The other thing that comes into play here is you as a patient may be on an anti-TNF, and perhaps you have developed SARS-CoV-2, you've gone out and you've been swabbed. What do we do in those situations? Remember, these drugs because they're dosed either every other week, every 4 weeks, or every 8 weeks, or in a variety of intervals, they have what we call long half-lives, so they last a long time in your body. But you could get in a situation where you've developed symptoms, you've tested positive, and you're about to get your injection or your infusion of one of these drugs. The recommendations now are that you should wait at least 2 weeks from symptom onset before you take your next dose of drug. Some of you may have lingering symptoms, and we would recommend that you talk to your physician about that. So that's really sort of the landscape of anti-TNF right now. Again, I think that the data has pleasantly surprised us from the perspective of I wouldn't have wanted to be in a situation where, as a physician, having to discuss with my patients to come off these drugs, because again, I think they're transformational. For those of you who are on them in the audience, the benefit of that, and we wouldn't have wanted to see the opposite data where we'd have to start recommending during the pandemic that you'd have to come off of them.
Thank you, Remo. And Jennifer, I think you're there still, if you can hear us. What are your thoughts on anti-TNF therapy, and specifically, what about starting dual therapy together with an immunomodulator? Are you doing that, or you're trying to start monotherapy right now, single drug?
Yeah, I mean, for new starts, I mean, depending on how, if this is Crohn's disease versus colitis and how the disease is behaving, wherever possible, I am leaning towards trying to select a medication that I'd be more comfortable with using as a monotherapeutic agent. That's not to say that I'm not considering starting an anti-TNF agent such as Remicade or Humira in select cases, but wherever possible, I'm trying to lean perhaps towards one that's a little bit easier to use and that I don't have to use in combination with an immunomodulator. But as was indicated previously, I would echo that these medications not be stopped because there is concern about being on multiple agents. Generally speaking, if your healthcare provider has prescribed these medications to you, it's been for a very good reason.
And one of the questions that just came up is if somebody's already on dual therapy, so let's say Humira and Imuran, or Remicade and methotrexate, should they stop the Imuran or methotrexate, and will that reduce their risk?
Yeah, so right now I'm not recommending that they stop it as far as contracting the disease itself. However, just to add on to what I said before, I think that if you happen to test positive for SARS-CoV-2 and you're on an anti-TNF, I would give you a holiday from your Imuran, your azathioprine, 6-mercaptopurine, they're all the same, or methotrexate, and until you've recovered from that. So I neglected to say that before.
Yeah, and that answers one of the other questions that we see here. Are we recommending coming off anti-TNF or methotrexate? And we really are not at this point. But I think that decision really also speaks to other risk factors, right? So myself as a pediatrician, I'm very comfortable starting an anti-TNF therapy with methotrexate because the numbers that are coming out in pediatrics of patients with COVID-19, almost nobody, I think nobody in the secure IBD registry or one or two kids in the secure IBD registry needed to be hospitalized and nobody died. So, can you speak to what risk factors you would think about, maybe coming off that second therapy?
Yeah, so I think it's really, really important. And when we segue into even starting therapy, our comfort level is probably different in different age groups, right? So as we in the secure IBD registry is showing similar data that it is in the general population, your greatest risk is really over the age of 65, right? So if you look at secure IBD registry, you think age itself, the mortality rate is about 28% in the over 65 group, if I remember correctly, is sort of the cumulatively. So in those situations, we would, again, I think in starting, we would maybe pick one of these drugs that doesn't have a systemic effect like Entyvio or Vedolizumab, which we'll talk about. And I would, depending on the disease state, when's the last time I saw them, et cetera, if you have an elderly patient, I think I'd be more willing to have the patient come off therapy, especially an immunosuppressant if they're still on it. That being said, drugs like azathioprine and 6-mercaptopurine, many of us are stopping those drugs when individual patients reach that age. And then there's the other flip side of comorbidity, which also comes into play when we're making these decisions, because that, again, sort of trumps risk of some of the medications we're talking about.
Right, so things like diabetes, asthma, and other things have been shown to increase your chances of bad outcomes of COVID-19, hypertension as well. So those are all, it's an individual decision that I think we try to make with the patient and figure out what the risk and benefit of each of these drugs are.
And there's another really important question that came up is, so if you stop taking Humira, and I think you could say the same for Remicade or the biosimilars, can you start taking again? And Jenna, if you kind of tell us a little bit about kind of these drugs are proteins and what happens to your body's immune system when you kind of start and stop. And
yeah, I mean, these are large proteins, antibody type proteins, and they're foreign to your body. Even though many of them are humanized or fully humanized, they're still not your proteins. And so what your body tends to do, just like any other foreign exposure, is it will tend to remember that you've been exposed to this and form a special type of antibody that will be developed if you stop the drug and get re-exposed to it again. And when we call that process immunogenicity. And when that happens, a couple things can occur. You can be less likely to respond to the medication when you're exposed to it again, because the antibodies that your body is making could destroy the medication. And the other thing is that in rarer occasions, you could develop some allergic type reactions as a result of that. So these aren't the types of medications we like to stop and start unless we absolutely have to. And for that same reason, is another reason why we sometimes will use these in combination with other immunomodulators, essentially to protect the antibody and to have some effect of the two drugs together.
Yeah. And what's really interesting is some of the newer generation drugs that we're just about to talk to, we're starting to realize that some of these immune properties are less common in these drugs. And I wonder if this is actually a good segue, Jen, if we could kind of flip to the next drug and get your thoughts on Stelara or Ustekinumab.
Absolutely. And so I'll start with Stelara. I know we're running late on time, but so Stelara is also known by its generic name Ustekinumab, and that was approved for treating moderate to severely active Crohn's and more recently ulcerative colitis. So just like with the anti-TNF medications, as I've said, it's an antibody protein, and it targets a chemical messenger that we call cytokines called IL-12/23. And this particular cytokine has been shown to cause inflammation in inflammatory bowel disease, and it's been shown in well-designed randomized controlled trials to be efficacious for inducing and maintaining remission in Crohn's disease and ulcerative colitis. So Stelara is initially dosed. I noted in the survey response that there are only about 8% of attendees that were on Stelara. So this may be useful information to some of you who are on the conference that are not on it. It's dosed as a single initial IV induction dose based on your weight at first, and then it's provided as a subcutaneous dose after that. And that can be done at your home by yourself or a family member if you're comfortable with that. So it can be convenient for that reason. The maintenance dose is typically given every 8 weeks, but sometimes that interval is narrowed to every 4 weeks, depending on how you respond to that medication. And your healthcare provider will together with you, assess your symptoms and try to determine whether or not that's needed. Stelara itself has been demonstrated to be quite safe. And really, there have been, to date, no observed increases in the rates of infections, including serious infections, in any type of research study to date, either short-term or over the long term amongst people living with IBD, as well as another condition, psoriasis. So there have been quite a few studies published, including clinical trials, registry studies, and combined summaries of studies that we call pooled analyses or meta-analyses, as well as post-marketing surveillance. So after the drug is released to market, adverse events are reported, and that is monitored very carefully. So as you've heard from our other panelists, if you were to get, we really don't know and have very little information about the risk that a medication like Stelara could pose to you in terms of acquiring or contracting COVID-19. If you were to get COVID-19, also the potential risks or benefits of being on a drug like Stelara are still uncertain. The amount of data is growing, as you've heard before, but the overall numbers are still relatively low, and a fair amount of uncertainty still exists. So having said that, to date, there have been no observed increases in the risk of adverse outcomes amongst people with IBD on Stelara, and specifically the secure database that Gil and Eric have been speaking about has not shown any major difference. But this is early days, relatively small numbers and unpublished data, but very reassuring for sure. And so for this reason, it's very important that more research is carried out in order to better understand the true risk or lack thereof in association with Stelara use. And certainly for me as a gastroenterologist, I'm providing care to a large number of patients with IBD during the pandemic. And I think in scenarios when a patient needs to be started on a new biologic, as I alluded to earlier, Stelara is a very attractive option given its known relative safety and ease of administration, that being subcutaneously. And it also has been shown to have low rates of anti-drug antibody formation, or this immunogenicity phenomenon that I mentioned a few minutes ago. So that sums it up, I think, for Stelara.
Yeah, no, it's excellent. And I remember some of the first use of Stelara was with anti-TNF therapies like Remicade and Humira. Some of our patients can actually develop psoriasis with their disease as a result of the drugs. And some of my early uses of it was when it was designed as a drug for psoriasis before it was even approved for Crohn's disease, and just recently for ulcerative colitis, that we were using it for psoriasis. And so it's one that kind of has a potential effect for different immune-mediated diseases, and then like you said, it's one where you give an IV induction and then every 8 weeks a self-injection, and so you get a good option in this scenario. And as you described in the secure registry, we're not seeing major signals of huge concerns with Stelara. I'm appreciating that we're running a little bit short on time. We do want to finish the session at 8:30 Eastern Standard Time. So rather than getting into a longer discussion around Stelara, and we realize that that a lot of the key issues, we've addressed already, maybe it's a good idea to pivot to the next medication as well.
Sounds good, Gil. And so the next one is going to be covered by Remo. I think he's hiding there a little bit. But Remo, what about the JAK inhibitors? Those are sort of the newest kid on the block when it comes to IBD treatment, and they go by the name tofacitinib for the generic name, or Xeljanz for the brand name. How do those affect your risk of COVID-19?
Yeah, so I won't go into a sort of huge sort of description of the drugs in general, but they are pan immunosuppressant drugs. They have a lot of effects. Many of the drugs that we've talked about as far as these cytokines are concerned signal through a pathway that's inhibited by or pathways that are inhibited by this drug. So the way I look at sort of JAK inhibitors is very, very similar to the way I look at sort of azathioprine or 6-MP that we've discussed. I wouldn't stop them if you're on them right now, but if you developed infection, then I think these are appropriate drugs to stop at that time. Now, again, this is very interesting because there's not many patients within the secure IBD registry on these particular therapies right now that are reported out. And so again, if you just look at the absolute number right now, it's about 10% as far as that outcome. So very similar to the overall population. The other interesting sort of side note, though, is one of the drugs in this class is actually being tested for that sort of cytokine storm, because it does have this very, very broad immunosuppressant effect. And the first sort of correspondence of that being used showed that it was protective. So I think the message is very similar. We don't think it increases your risk. You should stay on the drug. However, if you were to develop symptoms and those symptoms were related to SARS-CoV-2 infection, then this drug should be stopped. And I would use the same rules that you shouldn't restart it until at least 14 days after symptom onset.
So it's kind of interesting that it's another one of the drugs that maybe increases your chance of infection, and yet they're looking at it as a trial for COVID-19, similar to that dexamethasone story where we think prednisone may increase your chances of getting bad outcomes from COVID-19 because you're on it for a long time and it suppresses your immune system. But if you use a steroid for 10 days in certain people who are really sick, they actually do better. So can you explain that a little bit as to why that may be?
Yeah, and so we had this discussion yesterday, Eric, or we had this discussion on the COVID task force. Is remember, there's a difference between being on a drug and your risk on that drug versus introducing a drug that you've never been on, right? And may not be related to. Remember, the immune system of patients with, the underlying immune system of patients with immune-mediated diseases is somewhat different. That's why they're on these drugs. These drugs are being tested mainly in patients who don't have immune-mediated diseases, right? And so the effects, especially during the disease, may be different. If you've actually on these drugs and you develop SARS-CoV-2 and you develop COVID-19, then it's sort of suggesting that perhaps the way you're developing the illness and or the complications of the illness has a different pathway because it's not protective for you.
Great. Oh, you're muted, Gil.
Sorry, Jen, and even though we don't have a vaccine for COVID-19, there's a number of things that we can do to protect ourselves from other types of infections. I wonder if you could just talk a little bit about vaccines and prevention from that perspective.
Big topic. Okay, let me try to sum this up in 2 minutes. I think general principles. I think it's very important that that we explore patients' vaccination history, and that wherever possible, that if vaccinations are needed, that we implement them before we start treatment. We can certainly give them with some medications after we start therapy, depending on the vaccine we're thinking about. Specifically with respect to tofacitinib, I think that the one that pops out as being relevant in this setting would be vaccination for shingles. And, we've seen in some RCTs that the risk of developing shingles after starting tofacitinib seems to be elevated, maybe a little bit more magnitude than what's been seen with other biologics. And so we have some pretty good data to suggest and to recommend that patients that are age 50 or over should be vaccinated if possible by receiving the Shingrix or recombinant zoster vaccination before ideally starting the tofacitinib. And we even have some data, albeit less robust, that leads us to potentially recommend it when you're age 50 or less as well.
And Jen, there are both live and inactivated vaccines. And just to clarify for the audience, because shingles actually, the original one was a live one, and now Shingrix comes out as inactivated, just to give a sense of, the role of live versus non-live.
Yeah. So, I've universally shifted to using the newer non-live vaccination called Shingrix because it really is simpler. It's a simpler issue. The complicating factor for patients is that the non-live is a little more expensive, and they have to pay for out-of-pocket in many circumstances, not in all circumstances. Certainly younger patients often have to pay for that out-of-pocket. But it eliminates the concern about trying to administer the vaccination if you are a live vaccination if you're receiving immunosuppressive therapy, because you either would have to come off the therapy and wait long enough until it was safe to resume the therapy if you took a live vaccination, or you would have to delay starting your therapy for your IBD if you received a live vaccination. So it really does complicate things a little bit, and wherever possible, I will use the Shingrix, which is the non-live vaccination.
The non-live has actually been shown to be much more effective at preventing shingles down the road. So, and it seems to last longer as well. So those are good reasons to use the non-live.
Sorry, if I can just say one other thing about vaccinations, which is something that I think is really, really important during the COVID-19 era, is for all of you patients, for all the patients out there, obviously who are listening, is please, 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 please get your flu vaccine this year. You know, every time I'm on a call with a patient during, I said, I can see that we can see it in Alberta if you've been vaccinated or not. I said, please go and get vaccinated for the flu vaccine, especially if we have a second peak and there's some overlap in symptoms. So protect yourself. And even we know that patients who get into problems, if they develop SARS-CoV-2, they can get secondary bacterial pneumonias. So, you know, being vaccinated against pneumococcus or getting the pneumonia vaccine is also very, very important. So if you have the opportunity, please, please talk to your physicians about that.
And same for the parents of children. That's been a huge issue during the pandemic because of closures, that the routine immunizations are not being given to kids. And the last thing we need is an outbreak of measles or of chickenpox or through all of this. That's not what we want. So please, if your doctor is open, please get your child's regular vaccines as per the regular schedule as well. All right, so we should probably move on to the last medicine, and this one is for Jen. Jen, what about the alpha-4 beta-7 integrin inhibitors? Most people would know those better as Vedolizumab or Entyvio as the brand name. How do those affect your risk?
Yeah, I mean, Entyvio, just for those who aren't familiar with it, so it is approved to treat moderate to severely active Crohn's and UC, and it is a large antibody protein that targets a very special type of protein called alpha-4 beta-7, and that's for the most part unique to the gastrointestinal tract. And I like to explain it to my patients this way. If we think of our blood vessels as highways and our white blood cells as vehicles on these highways, then what Entyvio does is actually only blocks those dangerous vehicles that are fire hazards from exiting the off-ramp that leads them to the gut tissue. So if these vehicles are permitted to enter the gut tissue, then they can be bad actors and cause intestinal inflammation. Okay, and we're really talking about these vehicles are white blood cells. And so Entyvio is designed to prevent that from happening. And it's administered much like these other medications, initially as some induction doses intravenously at weeks 0, 2, and 6, and then typically every 8 weeks. But like Stelara, sometimes that interval has to be reduced depending on how you're responding to the medication. And although it's administered intravenously, Entyvio is a very safe treatment option. I say safe because some patients during the pandemic have worried about presenting for intravenous infusions at infusion centers. And certainly the infusion clinics affiliated with the patient support programs where you would receive your medications have implemented very appropriate safety measures during the pandemic, including all of the usual things like physical distancing, hand hygiene, and wearing of face masks. Entyvio has been demonstrated to be a very safe treatment option overall. Certainly outside of the COVID pandemic, no clinical trial, observational study, or pooled analysis has shown any increased risk of any type of infection compared to that same risk in people treated with placebo. And I think that, due to its gut selective nature, Entyvio has mainly been studied in IBD, so there really aren't any other conditions to compare these results to. In terms of COVID-specific risks, I think once again, the data is very limited, so there's still, a lot of uncertainty. In the SECURE registry, and Gil was discussing this on a session he was giving, an educational session for us here in Halifax the other day. There have been observed to be some larger numbers of IBD patients who've experienced adverse outcomes in that registry on vedolizumab compared to maybe some of the other biologics. But this issue of confounding that was discussed earlier is very important, particularly in this instance, because many of our IBD patients who are, not all, but many that are prescribed Entyvio are often prescribed this medication due to its gut selective nature because they're at increased infectious risk, and we want to confine that immunosuppressive effect to the gut rather than have selecting an option that would be more systemic in its effect. So specifically, older adults are often prescribed these medications, and older adults are at much higher risk of adverse outcomes related to COVID-19 infection. So we have to be very careful that we don't get too concerned when we're looking at those results from the SECURE registry at this point for sure. And Gil made another point, which is that, because of that systemic inflammatory response or that cytokine storm that can occur in severe cases of COVID, because Entyvio is gut selective, perhaps one of the reasons we're seeing some increase in adverse outcomes is it's not really having a benefit in cases that are more severe to treat or prevent escalation to that type of severe scenario. But once again, a lot more research is needed that evaluates the risk of being on a medication like Entyvio in COVID-19 and IBD for sure.
Perfect, thanks. And one question came up from the audience. We've talked a lot about bad outcomes from COVID-19. We've only touched on what's your risk of getting COVID-19 when you're on these drugs. Does anybody want to comment on that?
Yeah, I mean, I can comment on it. There's been 2 studies that have come out that sort of address this issue. One is actually from Spain, and it came from a group of a large IBD center in Madrid, which was the epicenter of Spain. And what they looked at was the crude incidence rate within their IBD population in the region, including mortality rate and that of the population in Spain. And there were no differences in the rate of sort of positive tests. Now, again, you need to take that with the caveat of not everyone was getting tested, et cetera. And then there's a multi-center cohort that was just accepted for publication. So I've seen the data for this from France and Italy, so combined, and they did the same type of analysis for crude incidence. And again, it doesn't seem like there was an increased risk in the IBD population as a whole compared to the population. So neither one of those papers really looked or had the granularity to look at all the drug effects and everything, but broadly taking a whole proportion of patients on a variety of drugs, it didn't seem that the risk was increased.
Yeah, and I think the overall,
because, if you think about the viral properties of how it's transmitted, it really shouldn't matter if you're on an immune suppressor or not. Like if you get exposed, you'll likely get infected. And so the key things is all of the measures that you're talking about: physical distancing, space between 2 meters, a mask if you can't do that. These are things that you can do to prevent and protect yourself from being transmitted, whether you are on an immunosuppressive drug or completely healthy. The truth is, if you don't do those things and you come in contact with enough of the virus, you'll get infected.
Absolutely. All right, so with that, I want to thank our panelists, Dr. Jones and Dr. Panaccione. Really appreciate the time that you took to prepare for this, and obviously, do a good overview of what the drugs are doing and what the risks are, and explaining it to the patients in the audience. It's really helpful. Thank you very much. So we now want to go back to that poll question that we asked you at the beginning. Now, if you answer it, how well do you know how your medications affect your risk of COVID-19? Love to see what your response is. All right, should we show the results? Much better. So we're now at over 90% are either good or very good. So I'm glad you learned something. I think that shows how well Dr. Panaccione and Dr. Jones were really able to explain it to everybody. So thank you to them for sure. So with that, we will call it a night. I wanted to put in a plug-in for our next week, our last webinar on COVID-19, at least for the summer, and we'll likely be reconvening in September in some form or fashion. But I'm really excited about next week's webinar, and that really will be about separating the myths from the facts. And we're going to get Professor Timothy Caulfield, who's actually a lawyer in the Faculty of Law, as well as in the School of Public Health at the University of Alberta, and he's actually a Canada Research Chair in the field. He's written multiple books, including his most recent A User's Guide to Cheating Death, which was turned into a TV series that was on Netflix last year. And then my favorite is Gwyneth Paltrow, Wrong About Everything. Just a spoiler, yes, when it comes to health. Let's just put it that way. but he's really an expert in trying to explain how you can differentiate bad information from good information, and how you can sort of not believe in all the conspiracy theories and try to distinguish good from bad data. If you want to prepare, you can look at his website, checkthenshare.ca, and that really is a really great overview on how you can distinguish good from bad information, especially online. So I hope you can join us next week for the same at the same time. And with that, I want to thank again all the essential workers out there, and for this Father's Day, all the fathers on the front line. We thank you very much for working and being out there, especially in the healthcare system and treating our patients. And as a final note, I do want to again put in a plug. Can you please donate to our Gutsy Walk team? The Crohn's and Colitis Canada is here to support you. The Gutsy Walk is the #1 way that research to find a cure or improve your lives is funded. And therefore, because Gutsy Walk is virtual, it's really important that you donate to people who are virtually walking. And that includes the team run by Gil and I. And there's your punchline. We finally did it. We raised $10,000 for the Gutsy Walk. That was our main goal. We're obviously going to increase that goal. We're going to go up to $15,000 right after this webinar. So if you find these webinars useful, if you find the services being provided by Crohn's and Colitis Canada useful, please go to that tiny.cc/COVID webinars and donate to our webinar team. We would really appreciate anything you have to spare to help out Crohn's and Colitis Canada in this time of great need. With that, I wanted to thank everybody for joining us. Please follow at Get Gutsy Canada on Twitter and on all the social media outlets. And I wanted to thank Gil as well for being co-moderator, and we will see you next week. Bye, everybody.